this is what the raising the bar is, because we've got this happening in the UK at the moment, and I'll explain what it means. It means raising the bar to try and improve MS services for people with multiple sclerosis. And so who's seen the movie The Perfect Storm? So this is actually the scene from The Perfect Storm. And I'm going to go through why I think we've got a perfect storm using these points. The first point is the epidemiology of MS, and this is what's happening in the UK, and I bet you it's happening in Serbia. The incidence and the prevalence of MS is going up. So what you're seeing in your clinics is more patients, okay? Not only more new patients, but you're seeing more older patients as well, because they're living longer, because we're treating them better. And so what's happening is your workload is going up massively. Just to give you an example, I was involved in a project in Scotland, in the Highlands and the Western Isles, which is where one of the areas of the world with the highest incidence of MS. And the prevalence has gone up 30%, 30 in 7 years. So all of a sudden, the healthcare systems there are having to deal with almost a third more patients than they had 7 years ago. And that's kind of a real worry, because what the hell is driving this epidemic? There's an epidemic going on. And if you look at almost every database that's collecting incidence and prevalence data, we're seeing the same problem. It could be Scandinavian countries. It could be Canada. A lot of the European databases, not to mention the Middle East. People in Kuwait, in Jordan, they're seeing a similar increase. So there's something fundamentally happening that's driving up cases, okay? And the other thing is we're seeing a change in the way we use DMTs. I just put this in here just to illustrate to you that what we're seeing is a massive increase in the more effective, the more risky, the more complicated therapies. And what we're seeing is the platforms or the injectable therapies dropping off. So we're hardly using these anymore. So we're seeing this shift away from what I would call moderate, low efficacy first-line injectables to the orals and the monoclonals. And this shift is happening pretty rapidly. And this is what we're seeing in our center. I arrived in my hospital in 2006, but this is when our new pharmacist came. And so way back there in 2011, we had only 280 patients on treatment. We've now got 1,200 patients on therapy. And so we've actually gone up 5 times in number, and there hasn't been an increase in staff for 5 times. I can be honest with you, we've had a small increase in staff. So we're having to work harder. It's unbelievable how overloaded we are. So there's this change, more patients, more therapies, more complicated therapies. Then there's also this push, and I'm actually responsible for this. I know that you've all read the Brain Health document, and it's been translated into Serbian. And the whole purpose here is to try and raise standards. In other words, what can we do to improve the management of MS? And we've got these quality standards, and we are now beginning to test these quality standards. We've created a tool to see if they're worthwhile testing. In other words, how quickly you diagnose patients, how quickly you put them on treatment, how quickly you escalate their therapy. Do you talk to them about holistic management or brain health, etc.? So I don't know if anybody in Serbia, one of the centers, wants to participate in this, what we call a pilot audit, just to see if the tool works in your environment. Okay. Then you all know that there's a lot of complexity, and I think we're probably a little bit more complex than Serbia, because Serbia hasn't got all the therapies yet, but it'll get complex. This is just how complicated it is in the UK in terms of different levels of activity, different levels of treatment. So MS is becoming quite complicated now. I think it's becoming a subspecialty in neurology. I think the days of what I would call general neurologists who don't have a specialist interest in MS looking after patients is going to be rapidly disappearing because of the complexities of understanding and using these treatments. And I mean, this picture, it may look simple, but it captures all the issues, how we classify MS into inactive, active, highly active, rapidly evolving, severe, how we monitor, and the different treatment approaches, as well as the prognostic profiling. And I always push this thing is that we now use rapid escalation or flipping the pyramid. But to do this, though, you have to have systems in place for monitoring. You know, regular MRI scans, neuroradiologists who know how to report scans, monitoring tools, so people who've got disease activity come to you. So I think the environment that we're practicing in is becoming more complicated. It's not becoming simpler, which is something that's adding to the need for super specialists. I'm not going to go through this. So this is what I would call the de-risking immunosuppression profile. This is in a publication but just to explain that for each DMT, there's stuff you've got to do at baseline, stuff you've got to do to prevent infusion reactions and infections, and then each drug has its own monitoring requirements. So this requires quite a large team. I mean, just give you an example. In our center now, we've had to hire somebody full-time, quite a junior person, but that person's job is just to monitor alemtuzumab-treated patients because of the monitoring requirements. Yeah. And then there's the treatment burden and the monitoring burden. And so these are all playing into, and then the unknown unknowns and the known unknowns. So as you know, Donald Rumsfeld was famous for saying, this is this famous quote, when this was about Iraq. There are known unknowns. There are things we know that we know. There are known unknowns. That is to say, there are things that we now know we don't know. But there are also unknown unknowns. Those are things we do not know we don't know. And I like to call this the Rumsfeldometer. And the reason why this is important, because in the UK, way back, when the anti-TNF alpha therapies arrived for treating rheumatoid arthritis, the rheumatologists put together a register to monitor patients on these new therapies. And they picked up a lot of unknown unknowns, you know, adverse events that occurred from being on anti-TNF, like lymphoma signal, like tuberculosis, like demyelination. I mean, this register that the rheumatologists put in place really identified an enormous number of rare, very rare adverse events from anti-TNF alpha therapies. And so we in the UK are trying to replicate this register with a register of our own to try and do exactly the same thing. So I think it's important, though, that if you as a country are using drugs like ocrelizumab, drugs like natalizumab, or any of these newer therapies, you should really have a system where you collect adverse events and compare them to other therapies. So I would urge you as a country to try and get together as a network of neurologists, MS experts, to put together a pharmacovigilance register so you can monitor these things. Then there's also changing services. So this probably has hit you, it's hit us. We're trying to get away from too much face-to-face, the blue year. We're trying to move to telemedicine, even group clinics, and even just email clinics. So we got the whole hybrid model emerged. And COVID-19 has really turbocharged, really sped up our service changes. And then you may have read this paper. I urge you to read it. What's happening is the European Charcot Foundation, the ECF and ECTRIMS, are trying to put in place an accreditation scheme. In other words, you as a MS center get an accreditation, a quality standard to say that you're an MS care unit. And they are saying that there's now a need. I'm not going to go through this, but they are arguing why it's important to have MS care units. Okay, they haven't made a statement about subspecialty validation. In other words, as a neurologist, do you need a certificate to say that you're an MS expert? But what they're saying, though, to run a really good MS service, you need quite a lot of things in place. And they call this MS care unit. And there's a little diagram what we think is the minimum requirement for a multidisciplinary MS care unit. So I actually can see, and John Carlo-Comey, who chairs this with Per Sorensen, their vision of this is in about 2 or 3 years' time, there will be certificates, accreditation being sent out to MS centers. But to get the accreditation, you have to show that you've got what they call a minimum set of standards, minimum requirements to become a care unit. So lots of pressure on all of you. The other thing that came up in the UK is that depends where you go. And this is the 20 biggest prescribing centers in the UK. And we've normalized the data to just show you how variable prescribing is in the UK. So just take this center here, RRV. You can see almost half their patients, 50% are in alemtuzumab. Okay. If you take this center here on the right, RXN, no patients are in alemtuzumab, 0. So the question is, it can't be right. Is it right that half the patients in one center on alemtuzumab and in another center, 0 patients on alemtuzumab? So this is a worry, because people are not getting the same care depending on where they go. And that's why we started a thing called Raising the Bar. And I'm actually the director of this thing called the Multiple Sclerosis Academy. And this is where we train young people wanting to do MS. They come and do a residential course with us, and they come back 6 months later and present a project, and they get taught how to manage MS properly. And I'm going to urge you to put forward somebody from Serbia to come on this course. If you've got a young neurologist or a young trainee that you want to come on an MS Academy course, I'm sure we can get funding. But anyway, we've now run 2 Raising the Bar initiatives. And let me explain to you what Raising the Bar comes to now. And one of the issues around Raising the Bar is we need to actually manage MS holistically. And the kind of principle I always put down is this thing called marginal gains, is what you can do for your patients over and above treating MS. And I always give this example of Dave Brailsford. So he was a British cycling coach, and he was employed in 1997 when Britain came 12th in the Olympic Games, winning only 2 bronze medals. Do you see that? By 2000, they were 6th with 4 medals. By 2004, they were 3rd, again with 4 medals. And by the time they got to Beijing Olympics, 12 medals, winning 7 out of 10 events. And in London, they won 8 out of 10 events. Isn't it remarkable what an individual can do? And so the question then is, can we do the same in MS? Can we actually improve outcomes by focusing on small things? And this is why it's not just about treating MS with anti-inflammatory therapies and working on the pyramid, neuroprotection, remyelination, neurorestoration. This is what I would call MS-specific targets, but it's also focusing on all those other things that we know impacts on brain health and outcomes. So do you have in your center an anti-smoking clinic? Do you promote exercise? Do you improve diet? Do you improve sleep? Do you screen for comorbidities? What programs do you have in place to prevent infections? We now have evidence that recurrent urinary tract infections are bad for people with MS, for example. Do you optimize their medications? Okay. There's lots of little things we can do to improve, and this is what we're trying to focus on in Raising the Bar. I just want to give you an example. This is data from Canada of comorbidity. So this shows you the difference in outcome, between patients with and without comorbidities, and it's the time to walking stick. And the 4 vascular comorbidities are smoking, hypertension, high cholesterol, and diabetes. Okay, and peripheral vascular disease. Sorry, there's also peripheral vascular disease. And you can see that the time to a walking stick is 6 years earlier if you've got a comorbidity. And if this is the case, then we're missing a trick, because this treatment effect is bigger than the treatment effect of interferon beta. So, I think we're missing a trick by not focusing on all these other things. So Raising the Bar's got 6 things now. Okay, the first one is basically a work stream where you collect data in a registry and you do audits. You see how well your service is running every year. Okay, and that helps you, because if you've got data, then you can actually put in a case to your managers to get more staff if you need more staff. The second work stream is lifestyle and wellness. How do we improve patients' diets, exercise, get them to stop smoking and all that thing? The third thing is leadership. In other words, how do we train and give people leadership skills? And there's a specific course running now where we got our first batch of 8 people on our leadership program. The next one is actually creating an education or like a school for patients to make them partners. So how do we educate patients to become health literate? How do we activate them to self-manage, for example? Okay, and also to use them. If we have them participate by volunteering to help our MS service, we engage with them a lot more. Then we've got a program, a work stream focusing on the social determinants of health. How do we improve access to MS services? How do we reduce social isolation? How do we help with inequality? The things that some of our centres are doing around food security. A lot of our patients are unemployed now. They're lacking, how do we get them plugged into a food bank? How do we just help them? In other words, lift them up. And then we've got another work stream, basically, which is national studies and registries. So these are things that are done across the UK, and we promote them through Raising the Bar. And one of them is that pharmacovigilance study I mentioned, and we're about to start a pregnancy. So I'd like to urge you, as a country, to think about not doing exactly the same thing, but to see what you need in your country and setting up a program called Raising the Bar in Serbia, where you actually put in place a national data collection scheme, registry, for example. And when maybe you can put in place a education program for your next generation of neurologists, a training program. Maybe you want to put in place a patient program to train the patients, etc. So, I mean, I'm prepared to help you with this if you want. I can't do much because I don't speak Serbian, but I could help you structure this, and I'm willing to help you if you want me to do that. So, just to conclude then, I hope I've convinced you that we've got a perfect storm. Increasing number of patients, more complicated DMT usage, clearly a need to improve what we've got already because we're not all working to the best standards. How to involve patients with choice and monitoring, developing new service models, how to reduce variability, and not only focusing on MS, but also the other aspects that improve outcomes, and maybe starting an initiative in Serbia. So thank you very much.